Hello, everyone. Welcome back to Neurospicy Nursing. Today is another little mini lecture just going over magnesium sulfate. We're going to talk a little bit about the pharmacology of it as well as its uses in the OB world. So let's go ahead and get into it. So what is mag sulfate? So it is a mineral salt that's used in obstetrics specifically as a anticonvulsant and neuroprotective agent. So a lot of the um, seizure medicines that are out there, anticonvulsants, they are considered teratogenic. So that's why we don't give those during pregnancy, but it's okay to give mag sulfate because you need magnesium in your body, right? It's one of your main electrolytes. Um, for MAG, it's given IV for a multitude of different conditions, severe preeclampsia to prevent seizures, eclampsia to prevent another seizure after they've already had one, and then preterm neuroprotection. So just making sure if they do go into preterm labor, you're protecting the baby itself. And then it's going to work by depressing the central nervous system excitability and blocking NMDA receptors. So, a little bit more into the MOA. We talked about how it blocks the NMDA receptors. That's really hard for me to say. And it decreases the neural excitability. It also can cause vasodilation of the cerebrovascular specifically, which helps reduce the risk of ischemia. Because if you think about how preeclampsia and eclampsia works, they have that really, really elevated blood pressure. Elevated blood pressure and just high blood pressure in general comes from vasoconstriction. So if we dilate those blood vessels, they get more blood to their brain, and it helps with preventing ischemia, which could be like an ischemic stroke due to that really elevated BP. Or if you're thinking about the baby, there is constriction of the blood vessels in the placenta as well. So if we prevent that, then baby can get an adequate amount of blood flow as well. So magnesium in itself, it competes with calcium at smooth muscle sites, which allows for a tocolytic effect. We're going to talk more about tocolytics and what they're used for, so just hold on to that thought. Also, another thing that it does is raise the seizure threshold, um, just like in any primary anticonvulsant, like Lamictal or gabapentin, it does the same thing. So it is important because it's going to prevent seizures in severe preeclampsia and eclampsia. The WHO says it reduces the risk by 50%. It can stabilize the maternal CNS and reduce the risk of stroke. I just talked about that severe vasoconstriction can cause strokes, right? Because the lack of blood flow to the brain. It improves fetal outcome by providing antenatal neuroprotection before very preterm birth. What this, all in all, what this just means is we're also protecting baby's brain because we're dilating those blood vessels and baby's allowed to get enough oxygen and blood to its brain. And then all of the global studies around magnesium say that they reduce mortality and hypertensive disorders in pregnancy. So if you are confused about hypertensive disorders, I posted a lecture about that yesterday on my YouTube channel, just a little short lecture going over the 4 different types of hypertensive disorders. Make sure you watch that. Okay, when we give it, this is important, okay? So, when we have severe preeclampsia, we went over the definition of what severe preeclampsia is yesterday, but make sure that they have neurosymptoms like blurred vision, a unrelenting headache, those sort of thing, as well as if they have any renal or liver involvement. So we're talking about that epigastric or upper right quadrant pain. If they have eclampsia, so remember we talked about yesterday, pre-E is all the same things as E, which is eclampsia, but the difference is the active seizures. So they go over into eclampsia when they have an active seizure. HELP syndrome is very similar to pre-eclampsia, severe preeclampsia, but We talked about yesterday that those elevated liver enzymes, those low platelets, stuff like that. So they can end up with the seizure. So we're using it as seizure prophylaxis. And then we talked about the antenatal neuroprotection if they're less than 32 weeks of gestation. So the maternal benefits of magnesium sulfate, it's going to prevent seizures and prevents the progression to eclampsia. This is important because if you are having a seizure, it's not only going to reduce the amount of oxygen flow to mom, it's going to reduce oxygen flow to baby as well. It reduces cerebral edema and those vasospasms and vasoconstriction. It's going to lower the maternal mortality for hypertensive disorders, and it stabilizes the neurologic status in both baby and mom. So fetal and neonatal benefits, you've got the neuroprotection, so we're going to reduce the risk of cerebral palsy in preterm infants. It improves perfusion by stabilizing mom's hemodynamics. Hemodynamics as in that vasoconstriction, how mom's blood is flowing through her body. If we reduce that vasoconstriction, dilate those blood vessels, she's going to have less of a hard time perfusing. And then it reduces fetal hypoxia during maternal seizures. So like I mentioned in the last slide, if mom is having a seizure, she's not getting enough oxygen and neither is baby. So if we're reducing those seizure activities or preventing them, baby's going to get enough oxygen that he needs as well. He or she needs as well. All right, safety, monitoring, and nursing priorities. If you guys could take a screenshot of this slide is extremely important for your testing purposes, okay? The therapeutic range of of magnesium sulfate is actually going to be a lot higher than when we think of regular magnesium in the body. Okay, so its therapeutic range is 4 to 7 milliequivalents per liter for OB standards. We are going to monitor DTRs or deep tendon reflexes, their respiratory rate, and their urine output. Deep tendon reflexes, because of the fact that magnesium is technically a sedative, so the things that are going to decrease with that are obviously their DTRs. Normally, when you have preeclampsia, your DTRs are hyperactive. You have something called hyperreflexia. I talked about it a little bit in the last lecture. So they'll have a DTR plus 4. Normal is a DTR plus 2. So if you're expecting something normal for magnesium sulfate, they should have a DTR of plus 2. That's their normal. Plus 1, you're concerned, and then absent DTRs, we need to go ahead and give the antidote for this medication. Okay. The other thing, since it is a sedative, is the respiratory rate is going to decrease. So any respiratory rate that's less than 12, we're giving calcium gluconate. Okay. And then urinary output. So remember, urinary output is supposed to be 30 mLs per hour. If it's less than that, that extreme vasodilation that we have is causing inadequate perfusion to the kidneys. It's all based on MAP. If you guys remember MAP, we can go through it again if you want. I'm gonna put a little quiz question here based on MAP as well, for you guys to try to solve. But MAP, super important. Make sure that you know that as well and what a normal MAP is and how it affects the kidney perfusion. If you guys needed a lecture on that, let me know and I'll give it to you. Toxicity. So I talked about respiratory depression and the loss of reflexes or absent DTRs, and then cardiac conduction changes because it's affecting the smooth muscle. Too much calcium can also cause, or sorry, too much magnesium can also cause dysarrhythmia. So that's another thing that we have to make sure that we're monitoring for. And we are going to give calcium gluconate as the antidote for this. So why is it the gold standard? So this is something that's been proven in decades of trials, okay? And most recently, it has been reaffirmed in evidence reviews that this does work, and it works really, really well. It's going to be a lot better to benzos. So benzodiazepines are what we use for status epilepticus, if you guys remember that from ages ago. That's when we use benzos. But those also have some risk factors as well. But Also, they're just not as successful as magnesium sulfate when it comes to preventing seizures in eclampsia and preeclampsia. Also, it's been recommended by a ton of global health organizations, especially the who really, really endorses magnesium sulfate as a primary treatment. All right, here are my resources, and thank you guys for watching. I will get that lecture up for DIC and some of those other complications. The next complications are going to be on the placental complications, so make sure that you're watching out for that. All right, guys, thank you, and I will see you in the next one. Bye.